Okay. No, you're fine. You're fine. Yeah. You're not my favorite thing. Let me see if I do it. All right, so listen, guys. I'm gonna I'm gonna at least do the intro. We'll get this thing started. I know people are gonna come that are they're leaving other things and they're gonna be coming in here. I haven't done any intros for anybody because I let them do it themselves. But I am gonna do an intro for this. That's right. That's right. That's right. Dollar four. This is one, and we have several people in the room that I would like to say help make this magic happen. But Jean Marie is over there. Myself and this crew, Eli, really started. You know, Jared had this vision, and Jared Walker, and they'll go over it. Really had this vision of doing something different. A lot of people talk a lot of crap and don't get it done. Jared literally, they'll go over this, but um, he had no hidden agenda. It was pure passion. And today, what's our number today? I don't want to spoil it. So we'll see it. It's a big number in the millions of actually, writing off debt and putting literally pure bootstraps and volunteers to really push an initiative that a lot of people really said couldn't be done. And the reason I like it is because they said he didn't play by the rules, which is exactly how I work. You don't play the game, right? You need to stay in your lane. And so, with that said, I'll turn it over to these guys. Thank y'all so much for being here. Really appreciate it. Looking forward to it. So look, you get the magic clicker. Ooh. I don't know if it actually works, but they say, does it work? Click. There we go. Yes. Melise, I am with Dollar Four. I help run the patient advocacy team and set up all of our partnerships. I've got two great teammates with me today that are also going to speak, Eli Rushbanks and Erica Dowden. They'll tell you all about themselves when you get up here. How many of you heard Jared Walker speak last year? Okay, a couple. How many of you don't know about Dollar Four or Charity Care at all? All right, cool. You're about to learn the best secret in healthcare, the thing that nobody knows, or not nobody knows, the thing that people need to know. All right. So, Dollar for is a nonprofit. We're entirely mission driven. We are entirely philanthropy supported. Everything we do is free to patients. We are not selling data. We have, like we said, we have no agenda here, right? Our agenda is that we don't think a medical crisis should turn into a financial crisis, and we are doing that by leveraging charity care policies. This is our current mission statement. Watch it change in a month, um, but let's say what Dollar Four is really about is making charity care known, easy, and fair, right? So to date, Dollar Four has this number is out of date. It's 8.93 or 18.93 million as of today. It changes daily. We have a Slack channel. We post every time debt gets crushed. Let me tell you, it's a delightful emoji-filled zone. And if you'd like to become a volunteer with us, you get to enjoy that. But how do we do that? We do that through charity care. And this is the point where I turn it over to Eli to talk about tax law.
My favorite emoji in the Slack channel is the Bob Ross parrot. So probably the main reason that charity care is the best kept secret in healthcare is because it is in the tax code, because that's not something that most people want to spend their time reading. So I am going to give everybody the Cliff Notes version of the federal law that requires nonprofits or nonprofit hospitals to have a financial assistance policy. But there's a few ground rules or things that I think I need to cover in having this conversation. So one, if I use the term charity care or financial assistance, same thing. What we're going to be talking about is 26 CFR 501R, which is the federal law that's in the tax code that came out of the Affordable Care Act. But most states have something that is, if not nearly identical, very similar. Where they differ is that most states will fill in some of the gaps and give some detail that is But 501R it wants for a few things that we're going to get into. But I want to give that caveat in that most of the time we're going to go over the general framework. There usually is some like substance that a state law in whatever state you're trying to implement this stuff. We'll probably give you a little bit more beef than the federal law. So with that context, before we dig into 501R, I guess I don't know what slide is next. Let's find out together. Okay, this is a helpful one for us all to be looking at. I want to give a brief overview of the tax law as it evolved from the 1960s to the Affordable Care Act, because that context is important in how to understand 501R. And understanding is important because it is such a vague, gray, non-specific law in a lot of ways. If we're going to squeeze out all of the patient rights from it, it's really important to understand it in context. Both of the history that it came from and of the laws that work with it. So, back in 1969, it was essentially asked for the first time, why do hospitals get to be nonprofit, or why can a hospital be a nonprofit? And there was Revenue Ruling 69-545, which essentially said you have to be a charity to be a 501c3. And we're just deciding, because of history and law and whatever, that the promotion of health is a charitable purpose. So that's it. If you're promoting health, you are eligible to be a 501c3. So they gave some very vague guidelines as to how an organization would promote health in a way that's charitable. They said they used one example of a hospital. They said they were operating an emergency room for anyone in the community who was able to pay. So even at the time in 1969, they weren't thinking that providing discounted services or free services or services to lower income populations was important to be a nonprofit. But they opened up their emergency room to the entire community. So that was the promotion of health. So that counted. They used the excess revenue, which I think is a hilarious way for the tax code to say profit when they're talking about nonprofits. They use the excess revenue for the promotion of health, and such as reinvestment in facilities, education, patient care, research, things like that. So they didn't have shareholders that they were pocketing this money. They were putting it back into at least allegedly putting it back into the organization. They had an independent board of trustees, and they opened the use of the hospital facility to other medical professionals in the community. So that was it. This is a 4-page opinion by the IRS. It wasn't even a statute. And that was essentially the guiding post for all hospitals who wanted to be nonprofits from 1969 until the passage of the Affordable Care Act. So it was a pretty loosey goosey, gray, ill-defined standard that didn't require free or discounted care, didn't require service to low-income people. So Affordable Care Act comes along, and in 501R, or in what became 501R, was a requirement specifically for hospitals operating in this nonprofit hospital space. So it applies to anyone or any hospital that is required to be licensed as a hospital by their state licensing authority, and relies on the fact that they are a hospital for their nonprofit status. So that's why there can be certain type of like government-owned or county-owned hospitals, or hospitals connected with an educational institution like a university. They can get their 501c3 status through a different route than just being a hospital, so they're not going to be subject to this law that I'm about to go over. So the big picture out of 26 CFR 501R that is important for our purposes, I think, is 3 buckets of code. One talks about the hospital's requirement to do a community health needs assessment. One talks about the requirement to have a financial assistance charity care policy, which is, I'm guessing, why most people are here. And then the other talks about the collection policy that a hospital would have to have. And so what I want to point out that is interesting about the way 501R is structured, and where a lot of the state laws fill in this sort of substantive part that's missing from it, is that the code requires these documents to exist, but it gives very little guidance on what must be in them, which we're gonna find out. So, for the community health needs assessment, big picture, they need to conduct one every 3 years. It needs to define the community they serve, assess the health needs of the community. It needs to get input from a broad group from the community it serves. It needs to make an assessment. Um, it needs to make the assessment widely available, and it needs to create an implementation strategy for like what it's going to do based on the findings that it made. And so I'm going to break down each one of those parts in turn, and I've structured this to say what the law says, things that they must do, that they shall do, and then things that they may do, because that's a wiggly little word that runs throughout 501R is may. And there's, we can have conversations on whether some of those mays were originally shalls that were lobbied for, whether it was the legislature being sloppy, but it introduces a lot of confusion on what does a hospital actually have to do versus what are they being encouraged to do to receive these tax exemption benefits. So in the requirement of the community health needs assessment, they define the community that they serve. They may take into account a geographic area that the hospital serves, target populations, and principal functions of that hospital. With, like as a specialty, or if they do primarily maternity services or something in that regard. That's a weird one for me to be a may, that they may take those things into account in a community health needs assessment. But there are some more specifics in there. They shall take into account all patients in the area, regardless of their insurance or ability to pay. And this is one of my favorite sentences in 501R because it is really the first time in the tax law as it evolved that a hospital to receive tax exemption was required to at least take into account, whatever that means, hospital or patients in their community, regardless of their ability to pay. That explicitly runs contrary to what we heard in Revenue Ruling 69545, where they said they only have to take into account the patients who have ability to pay. They cannot exclude in this community area the medically underserved. They cannot exclude the low income, and they cannot exclude minority populations. And so, again, a really big expansion of what a hospital is required to do to get tax exemption that was completely lacking before. So, moving on to assessing the health needs of the community. This is another big one. One thing that they shall do is identify significant health needs of the community. What they may do is, in doing that, they list things that they may include in their consideration, which includes financial and other barriers to accessing care. That's a really interesting and unfortunate may to me, because it doesn't require a hospital and its community health needs assessment to evaluate how the cost of healthcare might be a barrier to access to the healthcare by the community to the hospital services. And it would have been great if they required that. What I will say is I think that every community health needs assessment that I've looked at since this came out does specifically state that the cost of healthcare is a barrier to access to care. So they're treating this as an access problem, which is great. They have to get input from a broad group of the community. So they shall solicit input from at least one state, local, tribal, or regional public health department. And they shall solicit input from members of medically underserved, low-income, minority populations, or organizations serving or representing interests of such populations, which again is great. They have to talk to everybody in their community, not just the people that they want to talk to or the people that can pay them. It says they may get input from healthcare consumers and consumer advocates, nonprofit community-based organizations, academic experts, local government officials, local school districts, healthcare providers, health insurance companies, private businesses, and labor and workforce representatives. Some of those, especially the consumers of healthcare in the area, is a really weird may to be in there, in my opinion, but they are not required to do that. In making the assessment widely available to the public, that is pretty straightforward. They must have it on a website, and they must have a paper copy available for public inspection at the hospital. And in it, creating the implementation strategy, every single one of those things that they identified when assessing the health needs of the community, they have to explicitly state in the implementation strategy how they're going to go about addressing that health need. And if they're not planning to address that health need, they have to explicitly state that they're not going to and why. And so this is one of the reasons I've given us all of this boring context and history about these reports that these hospitals have to do to check a box on their tax form, is because there's a lot of meat in those reports. These are often 40, 50, 60-page reports. They put the onus on the hospital to identify the health needs of the community, which can be a financial need now, and they have to say what they're going to do to try to address it. And so that often carries in reference to the financial assistance policy, the charity care policy. That's a tool that the hospital can list in their community health needs assessment, saying that we found that people can't afford our services. This is one of the things we're doing. And as we probably all know, there can be a huge gap between planning to do something and the execution of actually doing something. And so not overlooking these community health needs assessments can be important in advocacy work, because that is just an extra arrow in your quiver to go to the hospital to say, hey, you yourself said to the IRS, to the community at large, that this is a thing you're going to do, and I don't think you're living up to it. So that's a valuable document to read, and knowing what must be in there is important, so you know what to look for. So let's get on to the actual charity care policies that these hospitals are required to have. Unfortunately, this is probably the least detailed section I'm going to get into, because there just isn't a whole lot of detail for what must be in a financial assistance policy. What we do know is they shall have a financial assistance policy that applies to all emergency and other medically necessary care provided by the hospital. My second favorite sentence in this entire law. It shall include eligibility criteria for financial assistance. It shall include the basis for calculating amounts charged to patients. It shall include the method for applying for financial assistance. It shall include any information obtained from sources other than the applicant the hospital rely on, such as if they do a background check on their patients that apply or something like that. Shall not send a patient to collections within 120 days from the date they sent the patient their first post-discharge bill, and shall process an application received within 240 days from the date that the patient was sent their first post-discharge bill. So what's a little frustrating about that entire section is the requirement that they have these documents. There's nothing in 501R, for example, when it says it shall include the basis for calculating amounts charged to patients. Full stop. It says that it shall include eligibility criteria for financial assistance. Now, in theory, this is supposed to be read in context of all of the information that are conveyed to hospitals in the community health needs assessment section, and should, sort of the spirit of the law would think that they're supposed to be providing discounts to low-income patients. But the law is completely absent at a federal level as to what the level of those discounts are supposed to be. They just have some sort of policy. So that was a little bit of a letdown. That wasn't just that. I know that was a letdown because I talked to the person who was one of the original proponents who drafted an early version of this, and they said they were very let down with the final product, because it cut a lot of that more substantive, useful language. Fortunately, there's, I think, 11 states that have their own charity care policy that have some sort of floor and some sort of requirement. Oregon, Washington, just because that's where I'm home base out of. I know each have one that require some sort of assistance for anyone under, I believe, either 350 or 400% of the federal poverty level. Both of them requiring 100% discount for anybody that's within 200% of the poverty level. So states have really jumped in to fill a lot of that gap. But that was probably the biggest letdown with 501R as it stands today. So with the collection policy, we get a little more hopeful. The overview of the collection policy the hospital is supposed to have is that cannot engage in extraordinary collection activities before the hospital has made reasonable efforts to determine whether the individual is eligible for financial assistance. To be perfectly frank, I think this is probably the biggest area where hospitals are probably non-compliant. We just don't see them screening everybody before they send them to collections, or making a reasonable effort to screen people before sending them to collections. And and there are different rules that I'll get into for a patient that's submitted an incomplete application versus a patient that's submitted a complete application for how this is supposed to be, so as it's supposed to play out. So the extraordinary collection activities are selling an individual's debt to another party, reporting adverse information about the individual to consumer credit reporting agencies or credit bureaus, deferring or denying or requiring a payment before providing medically necessary care because of patient's non-payment, and any action that requires a legal or judicial process. So most things that a hospital would do once they transfer the debt or the alleged debt out of their hands would be classified as an extraordinary collection activity. So the reasonable efforts to determine a patient's eligibility is loosely defined in the code. There are things they, at least at a base level, have to do before they can engage in extraordinary collection activity. And that is approve a patient, or they have to approve a patient for presumptive eligibility based on third-party information. And they have to notify the patient that they might be eligible for more relief if they fill out an actual application. So we don't see a lot of this in the patients that we help in the hospitals that we work with or against, however they choose to see it. Is some sort of actual use of presumptive eligibility screening. A lot of them will have it in their application, but it's pretty rare that, at least from what we see, that there's actually some sort of organized, cohesive way to get information about people and make some sort of presumptive determination. If somebody comes in the emergency room and maybe they're unhoused, and that's apparent either from their intake paperwork or the way that they present, that might be an instance where we see like a presumptive eligibility determination. They're not going to bill that person. But there is a requirement that they have to at least try to engage in some sort of presumptive eligibility screening, which is just not something we see them really do much of. So that's a good thing to know. That is one thing that we've used in appeal letters, is saying, this person is so low income that they should have been presumptively screened. Like, this shouldn't even be at the stage where they even had to apply. So we're way beyond that. They have to, so again, in the category of reasonable things that count as reasonable efforts to determine a patient's eligibility generally, at least the bare threshold that they have to do, provide a patient written notice that financial assistance is available, with a plain language summary of the hospital policy. So we often see that they will put some reference to a financial assistance policy if they have it on the bill, often in small print, that's sort of in the catch-all, like, hey, don't actually read this type of text that we've all grown accustomed to. What I do actually not see is that patients are provided a summary of the financial assistance policy. There's usually a link to it on the website, but I don't think the law makes clear at all that counts. So that's another area where I think hospitals are largely deficient, and where patients are getting hosed a little bit. And they have to make reasonable effort to orally notify the individual about the hospital facility's financial assistance policy and about how the individual may obtain assistance with the financial assistance policy application process. This is a huge one, because we have patients that we work with all the time. It's a story more than it's not that they called the hospital and said that they weren't able to pay the bill and were wanting to know if there was something they could do, and they were funneled towards a payment plan. And the hospital, in exchange for its tax exemption, is obligated to make a reasonable effort to orally notify the individual about the hospital facility's financial assistance policy. I don't have any data to support this, but my gut would say that more than 70% of hospitals in the country are not compliant with this particular provision. It's just not happening, until hospital patients really have to figure out the exact word to say, or the exact phone number. Often the number for the billing office is different than the number for the financial assistance office, and the billing people don't know anything about financial assistance. I guess I'm probably getting into Erica's territory, so I'll back off. Okay, so if a patient submits an incomplete application under 501R, they are the hospital shall notify the patient in writing, as to what is needed to complete the application, They have to give the individual a reasonable opportunity to complete the application. They have to suspend any extraordinary collection activities that they've been started, and they have to suspend that application window of the 240-day window. So that time doesn't count towards their 240 days it's told. And there's another one. We see hospitals deny for submitting an incomplete application where they can't do that. They have to follow up and try to get the additional information. If the complete application is submitted, their collection policy must state that they will suspend any extraordinary collection activities. They have to notify the patient in writing of eligibility determination, provide the patient a new written billing statement of the new amount that they're going to owe, refund any amount the patient has already overpaid. And take all reasonable available steps to reverse any extraordinary collection activities. Again, failure to refund is a huge one. We've seen hospitals that have it in their policy that you will not get a refund if you've made payments. In fact, we've seen it in more than one policy. So again, it's just an outright, on its face, violation of 501R. So I'm not going to go into detail on these because I anticipate other people that are going to present after me are, but the common areas that we have trouble with, specifically because 501R doesn't directly address them, are denying patients who are insured and having different rules for the uninsured, the underinsured, and the insured, and denials for people based on where they live, so residency denials. And a major, trying on the next slide.
It's not going. I was going to get you there.
Let me.
Nope.
I don't know what I'm going to. Should I point this at Jordan? Is that how it works? Well, let me try to pull it up here. Oh, I lost my mouse too. It's on here? Okay. Hang tight, people. We're going to push this out. What if I just click it? Here we go. Don't just click it. Just click the mouse pad. So this is a quick recap of the boring lecture on tax code that I just put you all through. And this is the most lawyered answer ever, but the answer to who qualifies for charity care is it depends. The 501R requires that they have a program, that they have a policy, that they have these documents in place. But what those documents say is going to be different hospital to hospital. The most cohesion that we see is when there's a state that has a robust law that gives them more stringent parameters. And then this is just kind of a short list of things that are going to be the biggest determinants of success in going through the financial assistance process. What I will leave you all with for my portion is one hurdle that we have in having impact at a more policy level than just individual patient to patient, which we plan to do patient to patient forever, is that there's no private right of action for any sort of lawsuit in 501R. And there's this crowd is probably familiar with QTAM actions, and you can't bring those for violations of the tax code. It's excluded. So procedurally, we're just sort of up a creek a little bit with how we would go about doing anything about it than just getting loud and maybe talking to our social media community or journalists about hospitals that are largely not compliant, because the only body that has authority to enforce this law is the IRS, and they're not doing it. So if anyone has IRS connections, then look me up on any internet outlet, because I would love an introduction. From there, is it Erica next? Erica's next.
Hey, thank you, Eli. How am I controlling this?
Just click that.
Just click.
Just click the mouse pad.
All right. Learn more. That was the last line of your section.
Learn more.
$4.org/manual. You can actually learn how to apply. It's not working for me. What am I doing?
Just left click it on the right side of the screen. Not or anywhere.
All right then.
You're there.
I'm going to go through how you apply for financial assistance. It's a pretty straightforward process, but it's often not easy at all, which is unfortunate, and it's something that we are trying to make easier for people, which we'll get into later. If you guys want to, you can pull up a browser on your phone, on your computer. You can walk through this with me. If there's a nonprofit hospital or network that you work with often, I don't know if anyone wants to throw out a name that they've worked with or know of in their area. Nonprofit hospital network. Anyone? No. Which one? Yeah. Okay. Okay. Thank you for being brave. Something out there. So the way this works is you're going to do a Google search. We find that this is actually one of the easiest ways to find your hospital's application or policy. Eli dipped into it a little bit, but hospitals is one of the actually clear things in 501R is that hospitals have to make their policy, their summary of their policy, and their financial assistance application available to view and download online. I don't know if download's in there, but people have to be able to view it online. It has to be easily accessible. Patients shouldn't have to have any extraordinary equipment to be able to access this. They should access it. If they can get onto the internet, they should be able to find it. It's a lot of words. So this is something you can do right now. If you can think of a hospital in your area, go into your Google browser, type in, let's say, Ascension St. Vincent. Maybe that's one or it's a mixture. Ascension is a network we work with a lot. Type in, oh, and here, this is better, Providence, Portland Financial Assistance. You can get even more specific, say financial assistance application, and a lot of times it'll pop up a PDF for you. If you go straight to the hospital's website, it's going to be available on there, but hospital websites are often really difficult to navigate. These applications and policies are kind of hidden. So if you're looking up this up for a patient, or you're looking it up for yourself, just suggest going straight into that Google search, Providence, Portland, or whatever hospital in the area, financial assistance, and it's usually going to be the first couple ones that pop up on there for you. You should be able to open it. You should be able to download the application. Sometimes a hospital will allow you to fill it out directly on there, send it. But often you download it, you can print it, you can do it on your computer. Pretty simple, but as you might see, once you start going through it, the applications are actually pretty detailed and they get a little cumbersome. So they're going to ask things like Eli was saying about your income, your household size. You have to be prepared to answer all these questions and as completely as possible, or a hospital will probably deny it. Usually they're a couple pages long. Again, it's straightforward, but it's often not simple or easy to complete. That was step 2. Yeah. Link. The policy should also be there, so you can review your hospital's policy, actually see if you're eligible yourself, see if you meet their criteria. Often they'll have this right here, which is going to be where you land on the pretty level. This is the main criteria for how hospitals determine if you're going to qualify by your income. So you can look up the number of your household, where you land on the current year's FPL, and see where that lands in the policy. Usually it's somewhere between 200 to 400%. You get some kind of discount or you get 100% forgiveness. Some hospitals will even have this in their policy, but most of the time they will not. You have to dig for it. But it's there. It should be. It's supposed to be. Who counts in a household? This is a question we get often, and a lot of hospitals actually define it a little bit differently. Sometimes they'll say it's whoever's living in the household. Sometimes they'll say it's whoever's dependent. Sometimes they'll say it's dependent on age. If you live with your parents, but you're not financially dependent on them, you might still have to argue with the hospital a little bit as to why you're not considered part of their household, because they will consider the income for your entire household, all wage earners that are a member of your household, so not just what you're bringing in. So that's important to understand. We define it as everyone who was in the same tax filing as the patient in the prior year. If the household has changed since then, marriage, divorce, birth, death, etc., patient's household should reflect the current household members. We hold to our definition on here. we hold really to the tax definition of a household. So if they are a dependent and they're being claimed as a dependent on someone's taxes, that would be their household. The hospital's going to consider that as their household. So say they're 18, but they're still a dependent on their patient's taxes, hospital's going to ask for that parent's income information. So those are important things to pay attention to. It's an important thing to know how to define because the hospital is going to need that or want that income information. And every application is going to ask that. They're all going to ask about your household size. So you got to know. We do have here on our website, dollar4.org/household definitions. Again, that's also part of our manual. We have all of this information available to you at all times and to your patients. We try to make it easy because hospitals don't. So hopefully that'll work. Did that work?
You can skip that one, Erica.
Okay. I don't remember how many slides are on mine. I thought there was only one. Like, oh, right. What if the patient has doctor bills? That's something we will help when it comes up. If a bill is in collections, again, this is something that Eli touched on. Nonprofit hospitals can send a bill into collections after 120 days. So I think it's a full billing cycle or however you want to say it. But after 120 days, they can send a bill into collections. However, they have to give someone 240 days from the first post-discharge billing statement they receive. So this trips patients up a lot because a lot of times they do have bills in collections. They think that's it. It's done. They can't do anything. When in fact, they still have 120 days to apply for financial assistance. If they qualify, hospital has to pull that out of collections, apply the assistance, forgive the bill, whatever, and they're good to go. But if you don't know anything about this and you receive a collection notice, how many people put up the white flag and they give up? Because it sounds pretty much done. And I don't want to say that that's the intention of a hospital, but it sure is effective at stopping patients from applying for assistance. So if someone says, but my bill's in collections, tell them, we're not done yet. We're going to look into this. You might still, and even if it's been past 240 days, it's still worth looking into. They still might be able to get help. So if that's a habit, it's not necessarily a barrier. It depends, like Eli said. What if the patient has insurance but still owes some to the hospital? Again, the tricky one. Every hospital kind of determines their own way that they deal with that. If a patient has a deductible, a lot of times hospitals will say that deductibles are not covered under financial assistance. We will still apply. We might even appeal that. Or send in a hardship letter, financial hardship letter, something. So again, it depends on the situation. It depends on the size of the patient's bill that's left over. Just by having insurance, it doesn't disqualify them necessarily. It just depends on what the hospital's policy is. So again, always worth looking into. If you still don't quite understand, always just say apply. Just apply. If you think you might qualify, get everything sent in and go from there. It doesn't hurt to try. They're not going to get in trouble if they apply and they don't qualify. All right. That brings us to our next section. If this seems like too much for your patients to handle or you don't want to do it on your own, we have a solution for you.
Yeah. So now that you know all the law, now that you know how to do it, we're going to tell you how not to. There is us. So $4. Anybody know the story of $4? Anybody know how we formed? Well, we formed a lot of years ago when Jared Walker, our founder's family, experienced a health crisis and started raising small dollar amounts in Portland, dollar for Portland, to pay off people's medical debt. And then Eli came along and pointed out that charity care existed and started applying for financial assistance. Now, let me tell you all about January 2021. Jared got on TikTok and he made a cute little video. Followed a trend. What's one thing you know that should be illegal? That's what it was, right? And he said, hey, let me tell you about charity care. And 34 million people watched it. And at the end of Jared's video, he said, if you need help, DM me. So you can imagine how that went. By the summer, of 2021, an amazing team of volunteers had gotten together and helped build a system to screen patients and help us intake them to do direct care, which was really good timing because then all of a sudden Patton Oswalt retweeted our TikTok. Uh, and and in September of 2021, about a year ago, we had about 1,000 applications sitting from patients who had come through our intake system and who needed help applying for financial assistance. That's about when you all met Jared, if you were here last year. We scrambled, we got volunteers, we had like a whole kind of crowdsourced effort to get those applications out. And by March of this year, we had successfully submitted over 1,200 applications for those patients. In the process, we built a system and we built a team to do it. So things are different at $4 now. Today we are a staff nonprofit with a team. We've brought all of our financial assistance work in-house in that we're not having volunteers managing patients' tax forms anymore, right? So volunteers still have a really important role in $4, but we have people like Erica, who didn't introduce herself as our patient advocate lead, but that is who she is, and a team of others who are really doing this work for patients. So we have two main service offerings that we have. One is full service. That means you give us all your data, you give us your documents, your forms, and we go and we run and we submit that financial assistance on your behalf. The other is self-advocacy. If you don't want to give us your documents, we don't care. We still want to help you. We will walk you through the process, remind you, step you through every step of the way. Again, entirely free, no strings attached. If you know 300 people in your community with medical debt, you can send them to us today, and we can handle it. We're ready to scale. Oh, no. What we do not. You all are pretty probably clear on this because of what you just heard us say, but just to clarify, because I think this is sometimes a point of confusion, we're not paying people's medical bills. We're not buying their debt. We can't help patients with hospitals that don't have financial assistance policies. We can't help with doctors' offices, dental offices, ambulances, pharmacies. Why? Because it's not covered by 501R. Right? So we are living in the 501R space. We are trying to enforce that policy for each hospital. So what have we done to do that? Well, we have a tool that lives behind these screens. That tool is a database of 8,000 hospitals in this country, of which our volunteer community has researched every policy and has put it into a database. So we now know what is the 100% forgiveness rate, the discount forgiveness rate, and the deadline, and the policy URL and the application URL for each of those hospitals. So if a patient goes to, it's a T letters, $4/help, it's on your card, it's on your QR code too. They're going to go through this 3-minute eligibility screener. They're going to fill out their name, their phone number, their email address. They're going to pick their hospital from a list, city, state, zip. If somebody's going through it and they can't find their hospital, ask them to check what city the hospital is in, not what city they live in, because that trips people up, right? And then they're going to tell us their bill amount. Rounding is fine. We don't need to know exactly. They're going to tell us their bill date. Again, rounding is fine, but we're trying to figure out how close are they to 240 days. And they're going to tell us how many people are in their household, how much money do they make. We're going to take that data, zip it through our fun little tool, and tell them, great news, you're eligible, or we're so sorry, you're not eligible based on either the age of the bill or your income. If they're eligible, again, they get those two choices. Full service, I want $4 to submit for me, or I'm going to do it myself. Fun fact, if they don't click a button, they get shoved in full service and we keep bugging them. Yeah, go ahead. I need your... I'll go there next. So, if they say they want, and again, remember, we're not screening them for if we're going to take them on right? We don't have any eligibility requirements. We're being driven by the hospital's eligibility requirements. So $4 doesn't say, like, we're gonna, you make too much for us to help you. None of that. If you qualify, we help you. Okay. So if you choose self-advocacy, yep. Oh man, I love that question, and I will answer it for you. Soon. The answer the answer is soon. Our system is kind of as we have automated to serve as many people as we want. It's gotten very complex, and we're trying to figure out now how to internationalize that. We are likely only going to internationalize in Spanish in the short term. Next week is my meeting where we're going to figure out what is our timeline for Spanish. As of right now, we do have one patient advocate who is Spanish speaking. So if a patient can navigate our system enough, has somebody on their end who can help them get through the English on their end, we can do our best to communicate with them. Our risk is going to Spanish speaking communities at scale because she's one person and she can't recreate all the automations. So that's what we're trying to figure out. But 6 months, really important. So if they choose self-advocacy, they're going to start getting these great emails. Here's where you download your application. Here's the steps. They're going to get emailed and texted along the way. Have you submitted? Have you submitted? Great. Now that you've submitted, it's been 3 weeks. Have you heard from the hospital? What'd you hear? Here's the phone number to call the hospital. Can you make that call? Right? We're going to kind of pester them through the process because, as we know, a lot of patients, people who have these bills, they're dealing with a lot. They're dealing with a medical crisis. They're dealing with poverty, right? And all the burdens that go with poverty. Paying attention to a financial assistance application, maybe not the top of their priority, and that's okay. We want to try and help move them through this.
Yeah, it gets
You're treating it like a man.
Now, yeah, we kind of broke it, but we're okay. We're figuring it out. Now, if they choose full service, this is where the fun happens. So you were asking how they prove their income, right? So if somebody chooses full service, they're now going to get asked to complete our full service questionnaire. They're going to be automatically given this screen. They're going to be, which is going to send them to the full service questionnaire. They're also going to get emails and texts for like 4 weeks, pestering them to kind of take that next step. Admittedly, this is a challenge to get people to take this next conversion step because this is a 15-minute form that can sometimes feel as challenging as filling out an application on their own. Our hope is that we're easing the process, but because it's an online form instead of something they need to PDF or download a PDF and mail or fax to an application, but acknowledging that there are challenges there and ways that we're going to have to make this more accessible over time. The other thing that we're doing is this is where our volunteer community comes in, is we're offering phone service to walk through this form for people. So for people who don't want to fill out a full form online or have questions, they can get on the phone with a volunteer who will fill out the form for them. Yeah.
So I asked a question about verify. You require them uploading.
Yes. So in the form, they are going to have to upload their financial documents. The reason for that is not for us, it's for the hospital. Because when the hospital requires an application, first they ask you to fill out the application that basically says how much do you make, and then they say prove it, right? So prove it normally means normally means this. Recent tax returns, 3 most recent pay stubs, 3 months of bank statements. That's what's most common. Some hospitals have absolutely wild lists. Send us a copy of your driver's license to prove that you're a resident of the state. Send us a letter from your college to prove that you're a student. Erica, what's the most ridiculous one you've ever seen?
It's probably shop. They ask for all of your utilities. They ask for any kind of like 401k, any kind of like retirement or investment, all of your bank statements. If you have the deposit from DoorDash or something, you need to explain it to them. They get very very detailed because they want to find out if you have deposits coming from anywhere that's not showing up on your W-2, your tax, anything that they can include as income. Some are more generous, but some can be very invasive. Did I hit the answer? So the tax return, pay stubs and bank statements, you get all three? That is normally what a hospital requires. Our full service questionnaire FSQs for short, asks for the tax return and either this or this. That works for most hospitals. For some hospitals, it's this and this, and then for some hospitals, it's also all these other things. So what we do is we take in what we think is like a reasonable amount of documentation to send to the hospital, and then we flag to the patient if we then, when we're doing their application, discover that it's more. Now, so here's the thing. We played all around all of these cool ideas, like what if we do a standard application and we send it to every hospital and they just take our model, right? Hospital said no. So we are at this stage of the game when they submit the application. Our patient advocacy team is literally taking all the data that they sent us, opening up the application from the hospital and transferring it. Automation is in progress, but it is automating 4,000 applications, so it is not a simple thing. But ultimately, what we are submitting to the hospital is that application customized to that patient from that hospital and those proof of income docs. Now, sometimes some intricacies here. If a patient is unemployed, they won't have pay stubs. That's like a big question we get. You want to send a letter. We always send a letter, right? This is patient is unemployed. This is how they're supporting themselves, right? Mom is giving them money. They're living off their savings. Here's the bank account showing the savings and how much they're pulling each month. Just enough to kind of explain to the patient or to the hospital how the patient is supporting themselves. Yep. Many patients these days use credit cards solely because of the percent back. Bank statement does not. Well, so they care about income, not expense. Now, sometimes a hospital will get deep in expenses, but it's more rare. What they want to see is, does this patient have money that's coming in that they could be paying to the hospital, right? Patients, some things we've seen in bank statements that are issues for us is gambling. There's expensive restaurants, vacations. No judgment. Yeah. We just don't. Yeah. There's nothing in their I mean, they're like, if they did and if they denied a patient based on that, like, the policy says it's an income requirement, right? So as long as the patient is under the income requirement, how they spend their income is irrelevant. I mean, if the hospital did that, Eli would be writing a very grumpy letter, is the honest answer. What is your patients to be able to take that next step to business? We're having this conversation today. It's about currently, and I will admit I haven't looked at it in the last few days, but I would say of all the patients that are eligible, about 20% will choose the self-advocacy route, which we would consider a conversion, right? Because they've committed to doing it themselves, and then another 30% will follow through with submitting an FSQ to us. So there's about 30% left over that just deem themselves eligible and then never, to our knowledge, take action. That doesn't mean that they don't. It just, we don't hear from them again. A lot of people, right? Afraid that they won't get the care that they need, not the best treatments for them. There's certainly big emotional component of it. So it's not from a position of exactly not wanting to do it. It's more being more fear, other commitments, it not being a priority. There's so many things going on in people's lives. We try and make it easy. We try and have the right messages, but the reality is, acknowledging that this bill may not be the thing that a patient is most focused on acting on. So just getting back to how we can help. I'm going to skip that slide. If you are in touch with a patient community,
What I am saying to you today is please send them to us. If you would like to track that, please follow up with me afterwards. I am happy to set you up with custom source tracking so that you know how many people are coming to you and what sort of are coming to us from you and what sort of outcomes you're getting if you have large access. If you're in a more granular space and you want to walk people through the process, we encourage advocates to actually take patients through the full intake process with us. So you could sit down with a patient, help them fill out the eligibility screener, and help them fill out the full service questionnaire, right? So you can hand them to us in a more complete conversion zone if you have the capacity for that. We can give you your staff trainings, we can give you more resources, we can give you flyers, we can give you social media, we can give you talking points, whatever you need to help get the word out, like we're game. And the one thing I will note is follow up, because this is a thing that I think patients get confused about. When we submit an application on behalf of a patient, the hospital thinks the patient did it. The hospital is literally never going to talk to $4, does not care who we are, and does not know our name. We put our name on it. We put a release of information in our application that gives the hospital permission to talk to us about the patient's case. About 25% of the time, that release just disappears into the ether. But we are committed to helping the patient through the end. What that means is that once the application has been submitted to the hospital, the patient does actually need to pay attention to their email, phone, and mail. They're going to get a letter or a call or an email from the hospital about if they've been approved or if something is missing in their application, whatever the next step is. And the hospital is not going to communicate that to us. So it's really important that patients be clued in and that they communicate with us. We have a whole system where we are following up with patients at, 3, 4, 5, 6, and 8 weeks, in addition to like 6 texts in there to try and help the patient communicate with us about what happened. But if the patient isn't communicating with us, we don't know the outcome. So actually, the funny thing about that 18.9 million is of debt forgiveness. It's probably a lot more. We just don't know it because patients have probably gotten debt forgiveness and not noticed or not told us. So that's our low bar for how much debt we've actually gotten forgiven. And we're at an hour, but we have a workshop next, which means we get to do a whole bunch of Q&A, or Erica can do storytelling, which is fun. What kind of questions can we answer for you all? Yeah.
I want to go back to eligibility for financial assistance.
Absolutely.
Did you say that if someone was in collections and they had made one payment, then they are not eligible?
Yeah.
Okay.
I don't think I said that. Nobody said that.
Okay. That's how I heard something.
They would have 240 days from the date that they were sent the first post-discharge statement to apply. That's the minimum amount of time the hospital must process it. And if they've sent them to collections, the hospital still needs to process it. If they're out of collections,
That's right. You did say that. Yeah, I remember that. Okay. Thanks.
Technically, under the law.
Thanks for clarifying.
Well, why don't we hang out for a minute or two and see if others come in, and we'll do a little reset.
Here's the next.
Yeah, please do.
It's like clear today. I don't know. So you have to speak about names. I think I'm watching something. That's why I'm actually here, and I'm trying to conversation. Go for it.
So have you guys made attempts to obtain direct contact with any of the hospitals that you've serviced to try and facilitate this? Because patients, like you said, stop talking to you at some point. And it sounds like the drop-off rate, increases dramatically for what a low-income process they are.
Yeah. We've had varying conversations about helping from the hospital end versus helping from the patient end, and I think patient end.
Yeah, and there is a one of the things we're staying into is sending letters to hospitals that are like wildly non-compliant and saying, hey, want to point these things out, please fix them. We are happy to help, like have a seat at the table. We talked about it's going to start linking to some website and some people. Don't for no one's taking us up on to do anything like that. And but we are gonna start getting a little louder and like print media and stuff about these kind of non-compliant things we don't know what retailers. So when that starts, maybe they'll be their
It's interesting. I come from the Cancer Institute. It's like, and I don't know how compliant we are per se.
not Americans.
Yeah, but I do know that our financial counselors that try to outreach, they just don't, we don't have any of them, you know, on staff institute like that. So we have time. But I mean, I do see them, you know, get those applications, we'll get that Christmas message right off all the time.
Providers.
I don't think I've ever heard of
What was that? We're gonna.
Personally,
because we've seen it.
The biggest one for the city is
So there's like 10 or 15 cases.
Yeah.
Like, yeah, United States is just because they're not from the hospital. So if your hospital isn't on either of our area, probably it's pretty good about that.
It's not a location at all.
Yeah.
Some location in house is also we don't so you know. So it's hopefully it just means yeah they're using really well and they're getting catching things. Some hospitals are really great and they use the answer they catch them from the beginning. So I go through that process and at that point like there's no need. So it's hard because we only aware and capture information is having the so we already know that it's certain networks and upgrades that and there was many don't know. So I guess that would be it's because they're getting it. It's something you
yeah,
because the cancer hospitals they can be like
they can be, but like I said, I think maybe
yeah.
like it's a little hard for charity because you know,
So we have a fair amount of turnover, so I'm gonna do a 2-minute version. Cool. Okay. All right. Let's see if I can get this. Okay. All right, friends, you're getting a 1-slide version of this. I'm picking a slide. Here we go. Okay, so hi, we're $4. We're a nonprofit org that helps patients to access charity care. Our founder, Jared, would say that we crush medical debt by making charity care known, easy, and fair. What is charity care? Lots of people don't know. In the Affordable Care Act, there was a provision that then turned into an IRS regulation that Eli will tell you all about one day if you want to talk to him. I'm not going to get the details. But it basically says that nonprofit hospitals, in order to maintain their nonprofit status, must offer a financial assistance policy that basically forgives debt for low and middle income patients. Who qualifies? It depends. The IRS regulation is vague. And so it leaves tons and tons of room for interpretation. And the result is that literally every nonprofit hospital in this country has their own policy that says what federal poverty level you might qualify at, whether you have to be a resident, how old the bill can be, whether you can have insurance, all sorts of loopholes, right? At its core, though, most patients who make under 200% FPL are are extremely likely to qualify for financial assistance, and in many places that can be up to 400, 500, or 600% FPL for a discount, right? It really depends on the community, the hospital's generosity, everything. The IRS also requires that the hospital give 240 days from the initial billing date to apply. So this will almost, for nonprofits, will always, any bill less than 240 days old will qualify. Sometimes older bills work. Magic words, it depends when it comes to financial assistance. What does $4 do? We basically help patients navigate this process. Eric, you can speak to Erica, and Erica will go into the ins and outs with you as our patient advocate lead on how one might go and apply for financial assistance on behalf of a patient solo. I'm going to tell you what $4 does. $4 has an eligibility screener. I've handed you all the magic card. $4.org/help. If a patient goes to this website, they're going to get to a form that's going to ask them what hospital did they go to, how much was the bill, and how much money did they make. Those three data, and what's the age of the bill. Those data points are going to allow us to compare their bill to that specific hospital's policy. We've researched them all, and tell them if they are likely to be eligible for financial assistance. If they are eligible, which about 80% of people who use our screener are, so this isn't an uncommon situation at all. If they are eligible, they will then have a choice to get full service help from $4. We'll collect all their data, we'll collect their proof of income forms, and then we will help them submit the application and follow up with the hospital to get a resolution. Or they can choose self-service or self-advocacy, in which case we're going to send them emails, texts, manuals, instructions to help walk them through it themselves, but without them having to give us the financial assistance policy. A year ago, we were a very small team that had gone viral on TikTok, and we're struggling with helping people. Today, we are a fully professionalized nonprofit. We have scaled, and we have capacity to help people. So our ask to you is, do you know patient communities that need help, and can you connect them to us? Or is there another ask? Or do you need help? We'll see it.
Yeah.
So now we can get into it and answer any questions that anybody has. Eric can do fun storytelling on cases that we have. What's up?
I have a question. Why wouldn't the hospitals be providing this more regularly?
I can try.
Go for it.
I think in the early days when we started doing this, we thought the hospital's failure to provide the financial assistance they're supposed to under the regulations as a little more malicious than it is. I think these are massive organizations, and this policy is drafted and then approved by the board of directors, and the necessary training and what it really means doesn't really trickle down to the person who answers the phone in the billing office when someone calls. And so, I mean, I've literally called and asked about financial assistance. The people in the billing office have no idea what I'm talking about, and they have silent saying, "I'm reading your policy. It says this," and they don't know. And there's another number somewhere for the financial assistance department, but that barrier in and of itself probably deters over half of the eligible patients who call the billing department thinking that's what we would do. So there's just things like that. It's the incompetence that's either avoidable or unavoidable from an organization their size.
That makes perfect sense.
Yeah.
Yeah. And then where does the charity care come from? I'm sorry that I don't know anything about this. I find it fascinating.
So it's not a pot of money. And I know a lot of people, it kind of sounds like that, right? It sounds like there's a pot of money. What it is a trade-off. Eli, correct me if I'm mistaken here. Is a trade-off that the hospital is getting an enormous tax benefit by being a nonprofit, right? Like, they are not paying taxes. And so the law is saying you need to be providing a community benefit in exchange for the taxes that you are not paying, and that community benefit is writing off these bills. Now, let's be frank, most of these people couldn't afford to pay these bills anyway. So the hospitals would be spending a tremendous amount of money collecting going after the debt, like spending collections money, calling, everything that's involved in trying to get somebody to pay a bill when they can't afford to pay it, as opposed to writing it off. Like it's at Jared has had conversations with the hospital where they kind of say, like, yeah, like this is not bad, right? It's not going to put us out of business. Is kind of the takeaway that we've gotten from hospitals on. Is that clear?
Yeah, so I think that the write-offs are something that they are supposed to be doing, but then you as a patient advocate, you're able to advocate for that particular patient getting the write-off.
Exactly, because what doesn't exist right now, reviewing our slides that are coming soon, it's not easy.
Yeah.
It's not known, it's not easy, it's not there, right? Hospitals right now hold all of the power because the regulatory system isn't in place. So that means that hospitals aren't necessarily doing the work to notify patients, hey, you've gotten a bill and this is what you need to do. Or as you're leaving the hospital, by the way, here's an application. That teeny tiny sign in the ER probably not doing, right? It's not easy. Okay, so here's some fun facts that we haven't said out loud. Do you know how patients apply? They have to fax in their application. Do you have a fax? No, no.
Or snail mail.
Or snail mail. It gets lost in the mail.
Every time.
Every time it gets lost in the mail, right? So just the mechanisms to apply create substantial barriers. For a patient to get the application, print it, or have a PDF editor, both of which challenging, require assets that you might not have. Then find all their files. Then either print their files or get all their files to a fax system to fax it. Find the fax number, which most of the time is not posted online. But if you call a hospital and use the word y'all, by the way, y'all is a magic word. If you ever call a billing office, say y'all and just find out how much faster you get what you need from them. And then it's not fair, right? So do you have to do? Major cancer center in Texas that says that they only forgive. Major cancer center in Texas says that you have to be a Texas resident to get financial assistance. Guess how many of their patients are from Oklahoma? Right? You're done. Okay. We're not naming any names here. Hospital says that the maternity services are not, in fact, medically necessary, and so are not covered under financial assistance.
See the app, and I'll tell you.
No, we won't. So,
are these policies publicly available, easily publicly?
Yeah,
they're all on the website.
Sometimes the issue is what the policy says, breaking the law. Sometimes the issue is how the policy is implemented, right? So sneak peek at our game plan for the next 3 years. We want to make it known. We want basically everybody to know what charity care is, so that there's like a first step. You walk out of a hospital, you get a bill, you figure out if you're eligible for financial assistance. That probably means coming straight to $4, but it doesn't have to. It can mean going to the hospital and actually getting what you need there. Step 2, we want to make it easy. I don't have the slide up here. To date, we've crushed $18.9 million in medical debt. Our goal for the next 3 years is $150 million. Now, we want to do that for individual patients, both because it matters to those individual people and their lives, but also because it's data, right? If we know what is going on at hospitals and we can see trends, if we have enough data about how financial assistance policies are playing out, that we can see trends, this is where patients are being underserved, misserved, the law is being broken, the law is being misinterpreted, this is what they're doing really, really well. We can then make it fair, right? We can congratulate and celebrate the hospitals that are doing really good work and elevate them. And at the same time, point out where the inequities exist and hopefully get them changed.
So if I'm a hypothetical patient in need, do I have to have a bill that's been issued to me by the hospital before I'm eligible? And I ask because so I used to work at a hospital in their college months. Part of what we instituted was a sort of a pre-clearance process, right? Where we did a financial analysis, we knew, okay, work treatment is going to leave you with a $10,000 whatever it is. We had a program called Charity Care, but so one of the things we did was we would work with our charity care to try and get it handled proactively because we knew the process took forever.
I mean, wouldn't that be lovely if they all did that?
No.
But what was the bill had not been issued? There was nothing
The
for
answer is it depends. Some hospitals will, and Oregon is particularly good at this. When you get financial assistance, it's almost like a status. So what will happen is you'll get forgiveness for all of your bills that are 240 days old in that window, plus 6 months or 1 year into the future. So any bills that you incur in the next 6 months or a year, also forgiven, no paperwork required. Some hospitals won't even look at an application if they don't have a bill on file. Sorry, that patient doesn't exist to us. Nope.
It can also be an issue if there's pending insurance. They might not review you even if you have a bill, if that hasn't been resolved yet. They may not accept it, may not review it, so you have to check in.
Yeah.
My reading, and for people who are in the last session, this is all for nonprofit hospitals required to do this under 26 CFR 501R in exchange for their nonprofit status. But what the scenario that Lisa laid out, which is your question, I don't think they're mandated under federal law to process an application before a bill has been issued, but I don't think there's anything preventing them from doing it if they chose to. Scenario that Erica laid out, I think is illegal under 501R. They have to process that application because they're making a determination as to what percentage of the bill the patient is going to be responsible for. That's irrelevant as to how much insurance is going to cover. And so they have to properly process it.
On that note, Eli, we have an appeal letter from you, right?
We think we already talked about it earlier, but
good.
and that's a tough thing though. The promptly or in a timely fashion, it's not really defined. So, and a lot of times hospitals can take 30, 60, 90 days to review an application. They can take or 6 months or 9 months. They can take 30, 60, 90 days to review documents that we turn in subsequently, but they will only give a patient, say, 14 days to reply to like a request for more document. So there's definitely a discrepancy there in how how a hospital defines time.
So as I was getting on the plane today, I opened the bill from the anesthesiologist for my kids.
And the anesthesiologist doesn't work for the hospital.
Apparently not, which I knew. I mean, at least this one takes our
They still might be covered under the hospital's financial assistance policy, and the hospital is required to have a list of all the providers they work with who are covered under their financial assistance policy on their website. So you might still be able to be.
The No Surprises Act has been a big boon to this, right? Because I don't know this 100%, but this is kind of what I've seen. No Surprises, you never really knew. It was like some hospitals posted whether the doctors or the other practitioners at the hospital would cover it. Other hospitals had no information. It does seem like since post No Surprises, you see the list of who's covered and who's not in almost every bill. So it's something we should confirm, but it seems like No Surprises kind of forced that.
No Surprises is going to have more of an effect on whether the insurance company has to pay for that anesthesiologist, regardless of whether they're in or out of network. But I think that the fact that had to come to fruition has caused more hospitals to put that list online of who's covered in the charity care because they're starting to get a lot of complaints.
But the way it works is that those billing offices don't talk to each other, right? So what we tell a patient is if you have bills from other practitioners at the hospital, step one is to go to the hospital and get approved and get your letter. And then you take that letter to all the other billing offices and you say, I got approved for financial assistance. Will you honor this? And as you're going through the process, like call them and tell them you're going through financial assistance and ask them to pause your bill so that you don't go into collections while waiting.
What do you think the success rate with that, with these third-party providers in the hospital? I feel like it's higher than it should be because it's not mandated.
I think it's pretty high. Generally.
Yeah.
I'm going to celebrate one hospital in Georgia with
Northwestern.
North Side.
Northside Gwinnett.
Okay, Northside Hospital. It's a whole hospital system near and out of Atlanta. They are a brick wall. You cannot talk to anybody there. They do not answer their phone. What is the status of your application? Who the heck knows? But then everybody gets a beautiful approval letter and all their associated bills get covered. They are the weirdest hospital to work with, and I dearly love them. So they're fun. Are we in time? We got 10 minutes? Okay, good.
Got 10 minutes. I feel like I've got Saturday morning. Great. Yeah, I really do.
Questions? Does everyone have?
Sure. Share a question on them. I thought he said that like if we already paid a bill, let's say I have a friend that scrounged money together, paid a bill, that they got money to pay them back. Is that still something you guys?
You are entitled to a refund if you overpaid what you'd be required to pay after financial assistance has been granted. So you are entitled to a refund for anything that's overpaid under the federal law. So that's not a state specific thing. Whether the hospital is going to do it or not is a different question. But legally, yeah.
Tough one. We do fight for refunds if the patient, especially once we get them approved. We ask every time, so they tell us they're approved, we ask if they paid anything. We look into it and see if they're entitled for a refund. We have a patient just recently, we got $1,000 refunded who the hospital required them to pay, they brought in a child for some reason and required them to make a payment at the hospital at that time. She had no idea what to do. She paid it on a credit card, couldn't afford it. It was a hardship, so that's why they put on credit card $1,000. That was just a portion of the bill. Later on, we helped them apply. They were approved for $1,000, 100% financial assistance. The hospital wouldn't send the refund. So we actually had to go through a lot of hoops. We sent in appeals. We sent in a fancy refund request letter, basically mortgage demand. Outlining the law, no response. We actually had to go to the president of the hospital to get a response. And then we finally did get a refund. So it is possible if you can get to the right person, because like I said, they're legally entitled to it. Because she was approved for 100%. If she paid anything, she's entitled to have that refunded. If she had been approved for 50%, if she had paid, say, 60% of the total bill, she should have that 10% over amount refunded to her. And we'll fight for it, but it is a challenge to get a hospital to acknowledge that law. Simply because there's no one really regulating it. There's no one enforcing it.
Have you found that hospitals kind of target a particular disease state when they're doing, figuring out who they're going to give their charity care to?
So that's an interesting question. We have only recently started tracking the reason for hospitalization. From our perspective, the health story of the patient is almost irrelevant.
Right.
We make it optional. As a matter of fact, guess what? It hasn't flown to HubSpot. I figured it out yesterday. It was 1,400 back data points. So we're fine. Keyboard. Yeah.
Because patients that are just gifted this for however the hospital decides.
I mean, I don't have a good answer other than it feels like luck of the draw, which patients get notified, right? So the dream for $4 is how can we make society at large aware that charity care is part of this law? Or it is on the books, right? How do we make it so that, like, when a patient says to a doctor, like, oh, I can't afford this, the doctor says, well, this hospital has financial assistance. By the way, here's here's the website. How do we make it so that, like, the first thing you do when you get a medical bill is, go to Dollar Four's website and check if you're eligible? Like, how do we change the ethos so that people don't automatically lose hope when they get a big bill? Right.
So I guess that leads me to a second thing, just off of what you mentioned. Do you find that doctors are having a conversation around affordability with patients?
Uh, if they are, it's not a thing that we are, like, tapped into yet. I will say that one interesting development that we've had in recent years, in the past year, is med students. We're finding med students to be a community who's very interested in learning and knowing and getting involved in this work. And we see a lot of opportunity for us to be kind of like educating the next round of doctors, of social workers, of nurses, of all different types of care providers, right? So that, like, they don't have to do the work. They just have to know that it exists. Like, if you know nothing more than what's on this touch card, by the way, hand this to your Uber driver while you're out and about this week. Guaranteed, your Uber driver has medical debt. Mine did. It was from 2019. Your Uber driver, your bartender, the household, leave it leave it on the table in your hotel room. Housekeeping here, they have medical debt, right? Think of all the different people you interact with in your life who just need to know. Okay.
But how does it?
Word of mouth, TikTok, we're trying to build partnerships. If you're an organization that wants to get loud about charity care, we're in. Talk to me. We're gonna make it happen. We're gonna hire a comms director. We're about to go. Do a lot to get really loud. We also have a lot of media. We've been in the Wall Street Journal, the New York Times, we've been in the New York Times.
Got a few more coming up. Yeah, Wall Street News Journal, New York Times. You guys have been crushing. Yeah.
It's all going to major donors foundation.
People that have a lot of money that need to park that money somewhere besides a new Rolls Royce.
Yeah.
This is
Yeah.
way better. Go.
All right, shall we wrap? Do we need to get the room to someone?
We do in 2.5 minutes. Keep answering and asking questions. Y'all are fine. I can run this. You're fine. Yeah, Johnny, I mean, they got business cards, contact, but pretty much anybody here at this conference is like, hey, there's $4 people. We can get you in contact with them. Like, it's not a problem. We're one large dysfunctional family. It's okay.